I guess in the interest of time and people who have come in on time, we will get started. And I have the pleasure of introducing Dr. Lorraine Lipscomb, that is a colleague and an old friend of mine. We actually met maybe around 28 or 30 years ago on service internal medicine. I was the senior resident and Lorraine was there. As my PGY1 on service, so times have passed, and at some point Lorraine was the division head when I was at Women's College, and we did the reverse when I was the division head there. So our paths have crossed over the years. So it's really a pleasure to have you here, Lorraine, and to talk to us. I will briefly give an intro on Dr. Lipscomb, who has a very extensive CV. Dr. Lipscomb is now a professor in the Department of Medicine and Dalla Lana School of Public Health at the University of Toronto. She's a clinician scientist and endocrinologist at Women's College Hospital. And she's also the executive director of University of Toronto Novo Nordisk Network for Healthy Population. And that's where this background you can see is the area she works in out in the Peel region and out west. Dr. Lipscomb received her MD from McGill, following training in internal medicine and endocrinology, and master's in clinical epidemiology at the University of Toronto. That's where we have met. Dr. Lipscomb leads an internationally recognized research program in diabetes, and we have actually benefited from that as Scarborough Health Network has been sites for her research projects in the past, and she's had us involved with her, which has been amazing. She works in particular focus is prevention of diabetes, especially in women, an area that hasn't been explored with many by other researchers to the extent she has done. So she's published over 150 peer-reviewed articles, and she's now has grants from CIHR and Diabetes Canada, and she sits on the board of Diabetes Canada. So I don't think anybody is more qualified to talk about this topic than her. And our interest is that it's very interesting that east and west of Greater Toronto area is very similar in population. As we all know, we have a very high risk population for diabetes. We have immigration and movement from countries that have very high risk, including South Asia and Asia, in both areas of both Peel region and the Scarborough or the east end of Toronto. So I thought that it would be very appropriate to have her talk to us, share some of the experiences and the work they're doing with this funding that they got, and which she'll tell us more about it, and also to get some ideas of where we can go and how we can collaborate with our colleagues out west. So with no further delay, I'll hand over to Dr. Lipscomb, and thank you again for taking the invitation in your very busy schedule, because I know you're very busy these days. Thanks a lot. Go ahead, Laura.
Thank you so much. And thank you, Afshan, for inviting me to talk to you today. Thank you for that wonderful introduction. And I can say that I'm just, so thrilled to speak today, and Afshan and I go way back. So I really appreciate the opportunity to talk to you today about what we're doing with the Network for Healthy Populations. Apologies for the date on my intro slide. Forgot to change it, but we are October 8th, in case anybody's confused. Let me just go through. Yeah, these are my three objectives. I'm going to spend, I know all of you are very well versed in diabetes, and I hope that I'm not repeating things that you probably already know a lot of this, but I thought it would be important to sort of set the stage around where we are today with the epidemiology of diabetes and the epidemic, really, both globally and locally. And before I talk about what we're doing with the network, I thought it was important to sort of remind people of, why we're at this state right now with diabetes. What is the role of social determinants of health, and how does that help us understand what research and policy action we need to take? So then I'll tell you a little bit about our network, and maybe just spend the last, I only have like 1 or 2 slides just to talk about some of the challenges and opportunities that we've had, but just more an opportunity to get your feedback on how we can, leverage this opportunity to also address the challenges. These are some of my disclosures. As you've already heard, I'm the executive director of this Network for Healthy Populations at University of Toronto. It is it is funded by a donation, I'll talk about it more in a moment, from Novo Nordisk Canada, which is matched with funding from the University of Toronto. So I receive funding from the university, but based on this donation. And you heard I'm also a member of the Diabetes Canada Board of Directors. I receive research funding from federal and provincial agencies, and I'm a practicing endocrinologist. So obviously, you all know that the global rise in type 2 diabetes represents one of the most pressing issues of our time, or crises, where it's continuing to grow. The latest data suggests that now diabetes alone, in addition to all the other chronic diseases, is affecting more than 828 million people in the world, with projected increase to 1.3 billion by 2050 if we don't do anything. This is a recent map from 2024, just to kind of give you an idea of where the cases of diabetes are highest. Obviously we're right here, Canada and the US, we've got a large number of cases. The prevalence, we don't have good data on Canada, but the prevalence in the US is about 5%. That's probably an underestimate around the world because these are diagnosed cases. But you can see, if you look at China and India alone, in sheer numbers, make up the two of them alone make up the largest cases of diabetes in the world. They make up almost 50% of all the diabetes cases just from those countries. With India having 212 million, a prevalence of 26%. China, 148 million, a prevalence of 18%. So this is really where, we're just seeing the tip of the iceberg now in our as these people are coming and emigrating to Canada. This is another paper out of the International Diabetes Federation that tried to project what's going to happen in the next by 2045 if we don't do anything. And worldwide, they're saying we're going to expect another 46% increase. But then they color coded the world to say where the increases will be in these different regions. North America is expecting around a 24% increase, but the biggest increases are seen in these third world countries. Africa, 134%, Middle East and North Africa, 87%, and South and Central America, 50%, and Southeast Asia, 60%. So really the biggest rises are in these more developing nations. Back in 20 years ago, or 1995, does that take us to 30 years ago? Right? Is that true? Yeah. Oh my God, 30 years ago. Sorry. This was a study we did looking at Ontario data. And 30 years ago, the prevalence using Ontario data was 5.2%. By 2000, it was up to 6.9%. And back in 2005, 20 years ago, it was 8.8%. And we had published this paper, which got worldwide attention simply because by 2005, we had already surpassed the global prevalence that was projected for 2030. And so clearly people were not prepared for this big rise. And since 2005, the rates have continued to rise. This is Canada from 2005 to 2025 with projected increases to 2035. These numbers look higher because Diabetes Canada includes people with both pre-diabetes and diabetes. So if you take both of those populations, we're at about 1/3 of the Canadian population. Continued projected increase over the next 10 years. And this is how much it's costing the country right now, about $12 million a year. Now, not only are we seeing this big increase in diabetes around the world and in Canada and in Ontario, but we're seeing a disproportional burden of diabetes in more socially disadvantaged populations. The overall prevalence for just diabetes alone in Canada is estimated at around 10%. But if you look at our Indigenous communities, rates as high as 17%. Visible minorities, South Asian, African, Caribbean, Black communities, 13% here. And also we see on the right here, diabetes by employment status and income quintile, showing that highest rates of diabetes are seen in those who are most socially disadvantaged, unemployed, lower income. And so it's really important that we recognize, and you all live this because you're working in this field of diabetes, and I see it too, that the people who are most who need services the most are also the ones with the least access. So this is something we need to prioritize. Now, why are we seeing this big rise in type 2 diabetes? I mean, very quickly, I think you can all appreciate it's mostly, sorry, why are we seeing this big rise in diabetes? Most places don't separate type 1 and type 2, but but they were able to model in this paper in 2023 what the rate of type 2 versus type 1 prevalence is, and you can see that epidemic is largely driven by type 2, no surprise. And in fact, they were able to show that when you look at the risk factors for type 2 diabetes, high BMI accounts for a little over half, with other factors such as genetics, ethnicity, and diet, etc. But high BMI. So this means that in order to tackle the type 2 diabetes epidemic, we also have to tackle the obesity epidemic that we're dealing with. And this again is just some graphs from global trends in obesity, both regionally across different regions of the world. Between 1980 and 2020, you can see that all regions have seen an increase in the proportion of people living with obesity, with, of course, not surprisingly, the highest rates in the Americas and West Pacific, interestingly, but rates increasing everywhere. And here is just looking globally, that we're now globally for both males and females at about a rate of 14% living with a BMI 30 or above, and with females actually having the higher rate now of obesity. In Canada, lest we think we are immune to this, as we all know, no, we are not. In Canada, we're now by 2018, this map is a little bit out of date. Obesity rates were about over 1 in 4, about 27%. And the red, this is Canada, obviously, but the red areas represent provinces where obesity rates are over 35%, and orange over 30%, yellow 25 to 30%. And you can, 30 to 35%, and yellow 25 to 30%. And you can see by 2018, we only had, most of the provinces were above 25%. So except for BC here, and I think that's it. So we're obviously we are dealing with a concurrent obesity epidemic. And so why has this happened? Well, it's no surprise that the trends in diabetes and obesity are rooted in changes that everyone has all seen to urban environments, socioeconomic conditions, and lifestyle patterns that have fostered unhealthy environments. And we know that despite their benefits, we know that the increase in income around the world, globalization of markets, urbanization, and technical advances have actually created societies where energy-dense, ultra-processed foods are now much more widely available, while opportunities for physical activity have declined. We now, can work, play, travel, and do everything with very minimal physical activity. We're spending a lot of time on screens. We're spending a lot of time in traffic, so those physical activity opportunities have declined. And of course, we all know that we're eating a lot more than we used to, and the quality of our diet has really declined. And so these changes have really made it increasingly difficult for everyone to make healthy choices, and such that the unhealthy choices have become the easier choices. But what about the role of social determinants of health? So obviously, we're talking more about sort of structural changes that have occurred in the last 30 years, but we know that certain populations who are living with social disadvantage, for example, are more vulnerable to diabetes, and so and obesity and other health conditions. And so social determinants of health refer to life circumstances that influence health outcomes, factors such as education, employment, living, and social conditions. And again, these conditions make it increasingly difficult for people to make healthy lifestyle choices. And this is just to illustrate this. This was a graph put out by the Canadian Medical Association, trying to sort of give a pictorial of what makes Canadians sick. And what they wanted to sort of drive home is that 50% of risk factors for illness are due to life circumstances, and listed here: income, early child development, education, etc. Another 25% access to health care, wait times, etc. But only 15% are due to your biology, and another 10% to your environment. So clearly, if we're going to really tackle particularly conditions like obesity and diabetes that are so affected by the ability to make to healthy choices and health behaviors, we really need to look at how these factors are influencing these factors. Now, when we talk about environment, even though it only plays a small role, certain environments are more prone to, have been shown to be more conducive to a higher risk of obesity and diabetes. And so many of our neighborhoods have now become, much less walkable, less access to parks and natural environments, transit, active transit like walking, cycling, or even taking public transit has become increasingly difficult for people. Our food environment, the ability to even access grocery stores and fresh foods has really become difficult. Housing with more urban sprawl and difficulty getting from A to B without a car. And of course, even air quality actually affects chronic disease risk. So all of these factors can also play a role. Now, this is just how do these upstream factors actually influence the burden of diabetes? And this is a figure that we put together to sort of help us understand kind of how social and structural determinants of health actually affect diabetes outcomes. Sort of like most of you will already be aware and know this. So I just it's just an illustration. So we talked about some of those structural determinants of health that are affecting all of us. On the diet side, cost and availability of healthy foods, too much ultra processed foods and fast foods, food marketing, and even people's abilities for home food preparation has really declined. And then along the lines of, ability to be physically active, urban sprawl, our neighborhoods, all those conditions that have now become more sedentary for our work and our leisure, labor conditions, and availability of services. But we also know that certain populations are at higher risk of diabetes, as I mentioned, and chronic disease, and they are disproportionately affected by these factors. So people who live with low income, recent immigration, ethnic minority, they're more likely to have some of these social determinants that can inequitably influence their ability to engage in healthy behaviors, and thereby increasing their health burden, which then can lead to worse diabetes risk and outcomes. And so that's just a kind of pictorial to remind people of, what we're trying to do here. So to tackle this epidemic, downstream approaches that toward healthy behaviors and towards improving health burden and access to care can have some benefit, but they may be insufficient for sustainable change. And as the epidemiologist Michael Marmot stated, why treat people only to send them back to the conditions that made them sick in the first place? So that's really what we're trying to do is, we obviously can't ignore those really successful interventions that help people engage in healthy behaviors, help people get access to medications and healthcare to improve their outcomes of diabetes. But we also need to help address the conditions that are leading to this cycle. One classic example of an intervention that's at that midstream around health behaviors is structured lifestyle modification programs for high-risk individuals. All of you may be aware of the U.S. Diabetes Prevention Program, which was a landmark study that randomized high-risk people who had already had pre-diabetes to either structured lifestyle modification program, metformin, or standard care. And you can see here that lifestyle modification over a mean of about 3 years was able to reduce the risk of progression to diabetes by almost 60%, better than metformin. And so this has really been the evidence base for targeting lifestyle behaviors to help reduce the risk of diabetes in high-risk individuals. And we know that so this gives us the proof of concept that these programs can work if we can implement them the way they implemented them in the trials in the people who are most motivated, like those in the trials. But unfortunately, effects have been more modest, as you can imagine, when we implement these types of programs in the real world. And this is partly due to the fact that we're not targeting those upstream social and environmental barriers that make it difficult for people to engage in programs and to implement and maintain behavior changes. And so this brings us to sort of the prevention paradox. So Jeffrey Rose sort of coined this concept, which observes that, while targeting high-risk people can really reduce disease for those, those most, the people who are most likely to benefit, whole population of the majority of people who are ultimately going to get the disease are in that low to moderate risk category and also are at an earlier stage of risk. And whole population approaches could stand to have a much greater benefit than just targeting high-risk people. However, most experts agree that we need both approaches to tackle the diabetes epidemic. And this is an illustration of this concept based on a cost and impact modeling study from my colleague Laura Rosella, modeling different strategies in Ontario. So again, looking at that DPP program, if we were to implement it in the province of Ontario in healthcare for the 10% estimated individuals, probably more than that, but if we say about 10% of individuals who have pre-diabetes and resulting in a pretty good weight loss, which was seen in the trial of about 7%, we could actually reduce about over 50,000 diabetes cases within 10 years with a savings of about $375 million. However, if we were to go upstream and implement a combination of population-wide policies that were more modest, resulted in a more modest weight loss of about 2.5%, but in everyone, targeting that sort of low to middle risk population, will actually prevent more cases overall of diabetes and save more money. And so this is why we need both approaches. And so indeed, the WHO put out a call to action for diabetes a few years ago. These are the 4 calls. One is to strengthen capacity, leadership, governance, multi-sectoral action for both prevention and control of diabetes for the large number of people who already have it. But also reducing those, but how to do it, reducing those upstream modifiable diabetes risk factors that we talked about, those health behaviors and social determinants, structural determinants of health, but also creating health systems that have integrated, person-centered, community-based and sustainable downstream diabetes care. So people living with diabetes get good, effective care. And of course, having high quality data collection and research so we can make sure that what we're doing is working and what isn't working, we don't do. And so with that in mind, I'm going to shift to this wonderful opportunity that we got at the University of Toronto back in 2021 when Novo Nordisk Canada and the University of Toronto made a combined investment of $40 million to address diabetes and chronic disease prevention. And thanks to a donation from Novo Nordisk Canada, this opportunity was intended to mark the 100th anniversary of the discovery of insulin at the University of Toronto in 1921. If you may recall that the University of Toronto sold the patent of insulin to Novo Nordisk for $1. They were able to then launch their company and introduce insulin to Europe. And so Novo Nordisk wanted to give back to the university for this opportunity that was given to them 100 years ago, and to mark the next 100 years of diabetes research. So they've given us 10 years of funding to be able to tackle the type 2 diabetes epidemic. So we started the network in 2021, which is basically to address the global crisis of diabetes with a local call to action. And we focused on the region of Peel, mostly because Peel region was based, Mississauga within Peel region had partnered with the city, with Novo Nordisk International to be part of their Cities for Better Health network, which is a coalition of over 50 cities that are globally focused on urban interventions to improve local population health. So that really gave us the opportunity to then leverage this partnership that Mississauga had with Novo Nordisk and with their global network. And so, but we expanded it to the region of Peel because we wanted to work with our public health agency there, as well as including Brampton, who I'll show you in a moment, are very hard hit by diabetes as well. This is a partnership between 3 divisions of the university right now. And we'd welcome opportunities in the future to potentially bring in the East campus of University of Toronto, but right now we are obviously University of Toronto Mississauga due to the local partnership with the city and the local focus on Peel region. But we're also working with Dalalana School of Public Health and Faculty of Medicine, who've both pitched in matching funding. All 3 have pitched in matching funding to help us build this network. And the guiding purpose of the network is cross-disciplinary research to reduce the risk and burden of diabetes, community co-designed solutions that would be scalable, and then to really use what we learn to share with other people who want to implement similar effective interventions. This is just to show you a map of the Cities for Better Health network put together by, that's run by Novo Nordisk International. Mississauga is the only Canadian city right now, and you can see there's a lot of cities in Europe and with some in Asia, all around the world. So what is our mission? So I've already sort of alluded to that, but more formally, because of the large impact, the unequal impact that diabetes has on socially disadvantaged populations, we feel that by reducing inequities and addressing those social determinants of health, that will benefit everyone. So our goal is really to reduce inequities and risk and burden of diabetes and related cardiometabolic conditions, because we know that that upstream work will have far-reaching effects beyond diabetes. Across the lifespan through better care, lower risk factors, and healthier living environments, starting with Peel region, but then learning locally so we can share globally. Just a word about Peel region, and I know that these characteristics of this region are very similar to Scarborough. In fact, we were fortunate to hear a presentation last week about the characteristics in Scarborough, and I can tell you it's really very, very similar. The Peel region, it consists of the 3 municipalities, Caledon, Brampton, and Mississauga, about a 1.4 million population, really a mix of urban, suburban, and rural neighborhoods, making it sort of a nice environment to sort of test out different interventions at that built environment level. Really large proportion are middle-aged and young, but most importantly is the sociodemographics. Almost 70% of our population in Peel is visible minority groups, with over half being South Asian and 15% Black and Caribbean. 52%, over half, were not born in Canada. 13% low income, and almost 50% are living with overweight or obesity. So really a really important area to address those social determinants of health and the diversity of the global population and the way the diabetes is affecting the world. And of course, diabetes rates, not surprisingly, are some of the highest in the country. In Peel, from 2020, 15.5% of adults in Peel living with diabetes, which is over 50% greater than the provincial rate of 9.8. And you can see there's quite a bit of spread with regard to the regional burden of diabetes across the region of Peel, with the darker squares being the areas that are hardest hit. And as I mentioned earlier, Brampton has some of the highest rates of diabetes, with some neighborhoods in Brampton being around 20%. And these are just diagnosed cases. And then we also, of course, not surprisingly, see that the highest prevalence of diabetes are among people who are living with these risk factors. So really important that we prioritize these, not just people with risk factors such as inactivity and overweight and obesity, but those populations that are disadvantaged. This is just to show you some projections for Peel region of where we're going to see highest cases of diabetes in the next 10 years using some modeling done by my colleague Laura Rosella, where you can see the blue bars are the number of new cases of diabetes we are expecting in the next 10 years, and the little diamonds are the proportion of population that will be affected by diabetes in the next 10 years. And so you can see our non-white Aboriginal or other ethnic minority populations are going to experience the biggest rise in new cases of diabetes and greatest proportion, and similarly among our landed immigrants and permanent residents. So these are the populations, once again, that we have to tackle, we have to address for prevention, not just for management, because these are the ones that are going to get diabetes in the next 10 years. And again, when you look at income levels, the people with the lowest income, less than 20,000 household income per year, are the biggest, are going to experience the biggest burden of diabetes in the next 10 years. So again, really driving home that we need to prioritize these populations. We also, just a word, we did a whole lot of maps, and you can look on our website to see some of them, but this is just a snapshot where we wanted to understand some of those built environment factors or upstream factors that are at the neighborhood level that are influencing, that we know are related to diabetes and obesity. And so these are just three of the factors we looked at: low walkability, low green space, and high fast food mix. And then we mapped the different neighborhoods of Peel region. I've just, the light green areas are the ones that have these adverse conditions, but don't have necessarily high rates of diabetes. But what we really wanted to know was what are those areas we need to focus on first that not only have these high adverse conditions, but also have a high rate of people already living with diabetes, as well as high rates of people living with social disadvantage. And those are those dark purple areas. So once again, driving home the fact that we need to focus on, some of these areas of Brampton, which we know are at higher risk of diabetes, but have some conditions that we could maybe work with our local planners to address: walkability, green space, fast food mix. So now I'm just going to move on to what we're doing about all of this. So that was kind of the background. We started in 2021 with some of that baseline data collection that I just showed you, just to understand what we need to do and where we need to focus. And then we've come up with this multi-pronged conceptual approach that I've put here at some of the at how we're organizing our work. So as I keep drilling home, in order to really advance our mission of reducing diabetes burden, we really need a multi-pronged, multi-level approach that tackles downstream to upstream environments of health. So at the micro level, we're working with our healthcare organizations and healthcare system in the region, along with patients, families, providers, etc., to improve the care that people with diabetes are getting. It really affects a small number of people, but the goal is really to reduce diabetes complications, address earlier screening, and also, with some element of diabetes prevention in high-risk people. But then we move also up to the meso level, where we're really focused on healthy living and healthy behaviors. And there we're really looking at those socially disadvantaged populations to be able to work with culturally tailored interventions that are co-designed with them. So we're working with community advocacy groups, community centers, faith organizations, workplace, school, etc. And then finally, and that'll affect our sort of middle to high risk populations. And then finally, moving upstream to explore innovations and policies and interventions that will help the entire population be healthier through healthier environments, working with our urban planners and municipal governments, public health, provincial, federal governments. So, and this is just a reminder of, some of you may know about the Ottawa Charter for Health Promotion that provides a roadmap for how to improve health promotion from downstream to upstream action: health services, personal skills, community action, supportive environments, and public policy. In terms of how we're going to do the work, so we are a research network. So our research projects are all partnered projects between academics and students at University of Toronto and local stakeholders, community members, community organizations, healthcare providers, health systems, patients, etc. And we are doing research along 3 streams: epidemiology and data science, just understanding trends and risk and evaluating things that are already happening; community-based participatory research, where we're working with local stakeholders to co-design innovations; and then implementation science, which really involves taking promising interventions that have been shown to be effective in other settings or in research settings and looking at ways to implement them locally and integrating them in practice and policy. In terms of, you know, what we're doing in terms of like the goals, so we had to start somewhere. So we had to say, how are we going to do all this? So we really started with kind of, well, we need to do it based on 3 goals. One is we need to build research capacity. So we need people to be able to do the work, and we need support for those people. We need to create reciprocal partnerships. If we're going to work with local communities and we're going to make sure things are co-designed, we need to make those partnerships happen. And that takes time, and we need to make sure they're reciprocal. There's mutual benefit. So we're not just going out there and saying, as a researcher, I want your data, please work with me. No, we have to find out what their needs are and their priorities are. And we also have to let them help us come up with the solutions that will work for them. So and that takes time and has taken us time. Obviously, we need to advance knowledge. So everything we do, we need to measure it. We need to make sure we have good scientific methods to be able to generate and demonstrate impact. So that's kind of our framework for how we're doing the work. In terms of the things that we're doing to realize these goals, sorry, it just keeps going back. We're very lucky again to have this funding, right? Keeps going back, I'm sorry. So we have funding for faculty support. Come on, stop moving. Chairs, students, community organizations. We have we have funding for cross-disciplinary, okay, come on, creating partnerships. And then we have catalyst grants, seminars, resources, and we have knowledge mobilization. Thank you. I'm sorry, it keeps turning. I don't know, I have to fix that animation. This is just a snapshot of some of the partnerships that we've created. I have to say this has been a very intentional and lengthy process to be able to work with these populations. Of course, our academic partnerships were easier because there's more alignment of goals there. However, working with those community partners has been more has been very fruitful, but has taken time. And then obviously we're working with public and government as well as national organizations. We're happy to say we have a really robust research and training program for students, both for undergraduate medical and Masters of Public Health students. And we've had a growth of summer students between 2023, 2024, and 2025, when we were able to increase our spots to 20. But we've also had a really large number of applications for students to work with us, and they've done some amazing work. In terms of our catalyst grants, so we also have funding to support 1 to 2 year projects that will catalyze new teams to come together, teams across disciplines, but also teams between academics at the University of Toronto and local stakeholders, and then catalyze those teams to come together and co-design local interventions or evaluate existing interventions and et cetera. And so these are grants. We've had a competitive process. We have a peer-reviewed process where people have submitted grants. We start with a letter of intent, and then they submit grants, they get reviewed, and then a few grants get selected. And we're very happy to report that we now have 17 funded projects in the region, with over 50 community organizations partnering with our academics at University of Toronto, and almost 2 million in funding. I'll just give you a snapshot of some of the projects that are being funded in the region. So at the macro level, we've got a few listed here along with the partners, an urban green space planning project, a nutrition and food literacy program, a youth physical activity program, as well as some health promotion initiatives that were co-designed with these partners. At the meso level, we've got a type 2 diabetes prevention program among young adults at the university and college level. So there are 2 colleges in the region, Humber and Sheridan, along with Mississauga University of Mississauga, as well as health promotion for South Asian communities. We've got a couple of projects there. And then finally, at the healthcare system, we're working with our local partners at Trillium Health Partners, as well as a lot of the community health centers and the family health teams, as well as community organizations that serve particular populations. And we've got a number of projects that are underway, a community-based diabetes screening program, a chronic disease management program for aging immigrants. We've got a centralized diabetes referral and intake and navigation hub that's being piloted in Brampton, a tailored pathway for the large proportion of younger onset type 2 diabetes among our South Asian and Black populations in the region, led by one of our young scientists, Calvin Key. I think he's done some work at Scarborough as well, and he's doing some really great work in this area. And then we've also got an integrated lower limb preservation pathway that's being led by one of our internists at Trillium, Dr. Terence Tang. I can tell you more about these in the questions if you'd like, but a lot of these projects are listed on our website if you want to learn more. We're also really pleased that thanks to the network that we've created, the partnerships we've created, and some of that seed funding that people have received, they've been able to leverage the network to actually get over $10 million in external funding. And all of these projects are run by our Network for Healthy Populations researchers and or our community partners, funding sources from everywhere from CIHR, Diabetes Canada, Public Health Agency of Canada. And so we're really excited about that. So I want to finish off just by summarizing, some of there's a lot of work still to be done. We are now entering into our 2025, we're entering into our 5th year. Next year, we're actually going to have a big summit in June. I hope, we can send out invitations in Mississauga to celebrate our 5th anniversary and then help us sort of strategize for the next 5 years and how best to use what we've learned in the first 5 years to really multiply our impact in the next 5 years. Currently, these projects are just starting. And so even though we've been around now for 4 years, like I said, it took a lot of time for us to create the strategy that was co-designed with our local partners, to do some of that baseline work and to get those projects off the ground, and a lot of those projects required a lot of foundational work just to build those teams and to develop those proposals. And actually, I didn't have time to explain this, but we actually supported those teams all along the way. Our Catalyst Grant program wasn't just a call for applications, but we actually started with letters of intent. And then we reviewed those letters of intent. And if they looked promising, we actually invited the teams for a workshop where we helped guide them on how to then develop the proposal. And so that was the way they were able to move forward, and they were able to identify new members for their teams as well, because we invited the broad stakeholder community. But in order for people to trust us and want to work with us, we had to start with creating all those partnerships. We also had to start with a priority setting. I didn't tell you that either. We did actually do a whole priority setting exercise with our community to understand what are the priorities they would like us to focus on. And we used those priorities to then launch our Catalyst Grant program. So I had to cut out a bunch of slides to sort of explain to you that process, but I hope you can get the idea that the reason why we still don't have a lot of impact is because we had to do a lot of that foundational work. But we're really excited for the next 5 years. So just to summarize, we have a lot of really great opportunities here that have been afforded by this donation and this network. We obviously we know there's a pressing local burden and unmet needs for diabetes. We have strong and motivated community partners. It wasn't that hard to make those. It was, people were ready. They knew that this was an important problem and they wanted to work with us. We also have that local government support, both from Peel Public Health as well as the City of Mississauga, and to a certain extent Brampton. We have dedicated funding for both faculty and students to be able to protect their time and build that capacity, academic expertise, motivation and capacity within the University of Toronto ecosystem. We also have that wonderful Catalyst grant funding, both for, and some of those projects actually are led by community organizations. They're not just held by academics. We also have that university matching, and that's really been critical to support the coordination and infrastructure and the team that I have to be able to run this whole network. And we have that long duration of sustainable support. But we're not without our challenges. So one of the challenges relates to our community partners find it, even though they're really motivated to work with us and they understand the importance of this problem, it is difficult for them often to commit the time and engage with us because they are so busy and overstretched. Getting those marginalized groups to engage with us is also difficult. Largely not necessarily because of trust, although that's part of it, but a lot of it just has to do with time poverty. They just don't have the time. Implementation of new models within busy resource stretch organizations, particularly in our very complex healthcare system. It is so challenging to get people to think about and be willing to change how they do things when they're just trying to get through the day with the overloaded roster of patients that they have. Connecting frontline stakeholders with upstream decision makers. That's been a real challenge for us, and it's my mission to make sure that our frontline stakeholders, our community members, our healthcare providers, and our patients can actually get the ear of the decision makers to understand, what they need and and how to make things happen in a way that's feasible and sustainable and effective. Measuring and demonstrating impact. There's so much great work going on out there, but it's really hard to get people to then engage in the research and the evaluation that's needed to be able to demonstrate the good work that's going on. People want short-term success, so we need to, but unfortunately, the only way we're really going to show true impact is by showing that we've moved the needle on diabetes and chronic disease. And so that's going to take time. So we really it's really challenging for us to sort of find those really good short-term metrics that we can link then to that long-term impact to say we're going in the right direction. And of course, even though we give funding for these projects to sort of be piloted and implemented on a short term, it's really important that we work with people who could then fund the long-term spread and scale and sustainable implementation. And sometimes that's not always so clear. And I'll stop there just to thank some of my core team members here. We've got our 3 research chairs, Haley Bannock, Ghazal Fazli, Beju Shah. We've got our executive committee, Laura Rosella, France Gagnon, and Moira Capral. And we've got our junior investigators and senior investigator, Jillian Booth, and junior investigator, Calvin Key. And then we've got our administrative team here, Dan, Fatima, Karen, Lydia, and Tiffany. And I will end there to leave some time for questions. Thank you so much for your time and attention. And I'll stop sharing, actually. We stop sharing. There we go.
Thank you so much, Lorraine. This was very interesting. It's really a huge work that you guys are moving forward, and good luck, because we feel the burden on this side of the city. So I had 2 questions. I know you discussed how hard it is to assess the impact, but what is your plan to look at numbers or look at ICS numbers, or what numbers would you look at in 5, 10, 15, 20? Like, what do you project as where we will see the impact? And then I have a second question. I'll let you answer the first.
Yeah, so I think we have a multi-pronged sort of evaluation strategy. So obviously, we're very lucky to have healthcare data at in Ontario through ICS, and we actually have a partnership with them. We did all our baseline analysis with them. We also work with Peel Public Health, who collects regular data on social and environmental factors. So we're definitely going to go back after, we've implemented some of these programs to be able to leverage the data that's already being collected. But obviously, and then the second strategy is relying on the local, the smaller teams to have their own evaluation strategy. So they're doing, surveys and qualitative interviews, et cetera. And then finally, we're actually working with Peel Public Health in the city of Mississauga, and we're hoping to extend to Brampton to create a regional health survey. So actually, to start with, we're working with Public Health Ontario to identify candidate indicators of short, medium, and long-term impact. Once we've identified those indicators and the tools to be able to measure them, then we're going to see what we already are collecting, and what we're not already collecting, we're going to establish a survey in partnership with our local government to be able to then do some regular evaluation at a citizen level. That's going to take some time and effort, but we've got a lot of interest and partners to help us do that. And then, of course, some of our impact is related to more academic impact. So we're really we're really rigorous about collecting information on where this knowledge is being shared and translated through presentations, publications, impact on policy, all of those things. And our team is working really hard on that. They have a whole strategy for that.
No, that's wonderful. And my second question was that you've done such a great work and come up with I'm sure there's some programs that you already eliminated, so it's not going to work. There are others that are going to work, and you've gone through that whole vetting process and got there where you are. But at what point would you be ready to actually share this across the borders of Peel to other regions? So because regions like Scarborough doesn't have those fundings yet, but they can use programs that's already been implemented in other regions.
Oh, that's a wonderful question, Afshan. And I think there are two ways in which we would do that. One is a lot of these Catalyst grant projects are still maybe, anywhere from 1 to 3 years from being able to evaluate what they've done. And so once they have, then the goal would be to use what we've learned locally from them to then share. We're working closely with, we have a partnership table with Ontario Health, for example, as well as Public Health Ontario, to be able to find ways to share what we're learning across the province. So but depending on if it's healthcare through Ontario Health or Public Health Ontario, if it's more sort of upstream work. And then the second way is we're really encouraging our academics and our researchers to leverage what they're learning locally to apply for bigger grants that they could spread across the province. And so there may be an opportunity. There's always a need to then, once you've shown some promising results in one region, to then look at opportunities to spread to another context. I think even from a research perspective and a knowledge perspective, I think Scarborough would be a really great, very comparable region to be able to test out things that we've done in Mississauga and Peel.
That's great. So there's a question in the chat that they said that they want to know, they're interested to know the prevalence of diabetes in Scarborough. I'm sure you know the numbers, and
I would have to look it up. I think
Yeah.
I think it was Ethel. I think she's there. Ethel may have
Yeah.
may have
But
presented that
our
last
numbers
week.
are very
Very
similar.
similar.
Yeah,
Very,
so we're
very
looking
similar.
at if the national is what 8-9%, we could be as high as 15.
Very
And
similar to
so we're
Peel.
very similar. And then when
Yeah.
they actually done the provincial maps with Dr. Jillian Booth has worked on that.
Yeah.
The two red areas are equally red, both in Peel region and in Mississauga. So we're the same. And
Yeah.
that's why the interest to work with this group. Yeah, but that was a great question. Any other questions online here? Or
I see Felix has a question.
Felix,
Hi,
go
Dr.
ahead.
Whitcomb. Great presentation
Thank
again.
you.
This is more of a, I guess, selfish question. So as we're working with Ethel and Scarborough Ontario Health teams in developing a pathway for Scarborough, I'm happy you mentioned that, you weren't able to show impact right away as you sort of build the groundwork. How do you maintain engagement with some of your community partners and to show them that, listen, we're heading towards something that's going to improve the care in diabetes, especially as, in management and leadership, we move around so frequently and there's always turnover. So how were you able to maintain sort of that progress through the years?
Yeah, it is a challenge, Felix. It's a great question. We have some principles, and one of the key principles is regular communication. So, and regular opportunities to communicate back to our community. We have I didn't mention this, but we have a formal, like those reciprocal partners. We also have a formal advisory committee, which makes up core members from that. There's about 20 people on that advisory, and we communicate with them regularly, not just, newsletters and things like that, but also we bring them back for new opportunities for co-design, to hear about the progress to date. We bring all our Catalyst grantees every year. We do a discovery day, and we bring the Catalyst grantees forward, and we tell them, like, we work with our Catalyst grant teams to make sure they know how to demonstrate the interim impact that they're having, to be able to keep our team engaged. But it is challenging. Another thing is we work really hard to find out what's important to them. And we make sure that they can lead projects. So some of our organizations are actually getting direct funding from us to lead the projects and to actually fund their own team members to work with us. So we obviously, one of our conditions is that they work with someone from U of T so that we can maintain that scientific rigor. But if they're leading, then I think it keeps them more engaged.
Thank you.
Well, thank you very much. I think we're coming up on time. Ethel sends a big thank you and says an excellent presentation in the chat.
Thank you,
Lorraine.
Ethel.
I
It was
think
nice.
we all
Thank you for joining. Yeah.
really appreciate you sharing the knowledge and look forward to maybe hearing back from you in a couple of years as you look at more of the impact of these projects. And thanks again for everybody and the interest of close to 50 people attending here. I really appreciate it. Have a good one, everybody. Thanks
Thank
again,
you so
Lorraine.
much.